sending it to you, but maybe it wasn't.
I think I've got it. I think I've got it recording to the cloud. So let's just go ahead, and then we can always run it again if we have to. Can everyone hear us okay?
Yeah.
Yeah, okay. I'm really sorry about the sound and being on my phone this morning. There's been some technological debacles on the way to setting this up. So the reason we actually meet quite regularly to go through chapters of the textbook, the medicine textbook Edinger, as a group of us. And we got up to the shock chapters, and I read the shock chapters, and they're wildly outdated already, even though that book was released very recently. I'm just admitting people to the waiting room. That's why I keep touching the screen. Sorry, everyone. So I really wanted to get Lucy involved with this talk because Lucy is a critical care vet at NEVS with us. And Lucy runs also FlexiVet training, and she does sort of CPR and emergency training for groups of vets and veterinary teams. So if you wanted to talk to her about that outside of this, that's you're very welcome to.
Thanks for the plug, Anna.
Hey, the plug.
Thanks for the plug.
But she explained this in, like, it just completely changed the way I use fluid therapy and the way I manage shock. So what I thought we'd do is just kick off by kind of going through the Edinger chapter. And essentially, like, the important things are defining shock. And I think the definition of shock varies between texts that you read, but the sort of brunt of it is that there's profound and widespread reduction in tissue perfusion, so delivery of oxygen to cells, and cell injury resulting from that. And then it ranges obviously from very mild or localized to generalized and very severe irreversible cell injury. So I'm going to just do 2 minutes of physiology so that we all kind of understand exactly what the cellular reaction to a deficiency of oxygen is. Cells require oxygen to produce ATP, which is the energy source in the cell. And that ATP is required for many cellular reactions, but most importantly for those sodium-potassium ATPase pumps, which keep the intracellular potassium level high and the extracellular sodium level high. We all kind of know that sodium is followed by water. So if sodium moves to, inside the cell, water's going to follow it. So as soon as we get destruction or decreased activity of those NAK ATPase pumps, and that active maintaining of the electrolyte balance isn't working anymore, we get sodium staying in the cell or flooding into the cell, water following, we get cellular swelling and cell death. So that's kind of all we need to know, except that cells, when they're deficient in oxygen, switch to anaerobic metabolism. So they try and produce energy through alternate sources. And one of the byproducts of anaerobic glycolysis is lactate. So that's important, obviously, as far as sort of diagnosing shock, because lactate is one of the things that we measure, and it's a measure of anaerobic metabolism. If it's lactate in the blood, then it's a measure of kind of global, how much anaerobic metabolism is going on a global scale and is directly related to the degree of perfusion. Does that make sense, Lucy?
Yeah.
Cool. So there's certain cells in the body that have an absolute requirement for oxygen. They aren't good at using alternate sources for anaerobic metabolism, and most importantly, neurons. So very early in shock, we will get a change in mentation because of the decreased oxygen delivery to the brain. So that's kind of the background physiology, and we could go into so much more detail, obviously, with sort of interleukins and cytokines and all of those things, which contribute to the pathophysiology and the progression of shock. But I think it's probably defeats the purpose. It's sort of beyond the scope of this chapter. So I wanted to talk about the different types of shock that there are, just because obviously management-wise, what's causing the shock is going to change that. I'm just going to let someone into the waiting room, sorry. Okay, we're in. So again, different references, different types of shock listed in the references. The list in Edinger is the one that I actually like the best. So there's a list of 6 different types of shock. The first, can anyone do, I didn't do slides or anything for this because I wanted this to be a bit of a discussion. Has anybody done any reading and want to kind of, you know, contribute to this? Like, first type of shock is hypovolemic shock. So can anyone think of an example of hypovolemic shock?
So probably the most common, like major hemorrhage.
Absolutely, yeah.
You could also have other ways that you lose your circulating blood volume. So like if you third spaced it, or I guess if you lost it through an organ, so like your GIT or through your kidneys.
Very, very good. So anything that decreases your circulating blood volume dramatically will potentially cause hypovolemic shock, and that can happen over a really long time. So Addison's is probably a good example of that, where they get renal damage due to just decreased circulating volume, but it happens over quite a long period of time in many cases. So that's excellent. So hypovolemic shock is probably one of the most common that we see, and I think probably second most common in my experience would be distributive shock.
Do you mind if I butt in before we move on from hypovolemia?
Yeah.
I think an important thing to consider with hypovolemia is, have you purely got hypovolemia, or do you have hypovolemia plus dehydration? Because I think like it's important to know the difference, because like if you just cut yourself and you bleed like a heme abdomen, that animal's not actually dehydrated. It doesn't have a loss of total body water, it's just lost blood volume. So that's purely hypovolemia. But those sort of dogs, like the really bad gastroenteritises that have now got hypovolemia, or the Addison's dog that's, you know, been pissing out for days and days and days, that's now got hypovolemia, they're dehydrated as well. So you need to kind of think of them as 2 separate things. You need to think, does this animal have hypovolemia, which is your like perfusion parameters like heart rate, respiratory rate, etc., blood pressure, and is it also dehydrated? And that changes how you treat it, like in terms of the volumes of fluids that you're thinking this animal's going to need. Yeah,
it's a really good point. So I think in Edinger that's sort of defined as either absolute or relative, and it wasn't very well explained in that chapter at all.
Yeah, and I sort of think, I mean, septic shock, we'll talk about that a bit more, but like it is effectively a hypovolemia, but I kind of think of it as a like relative hypovolemia. The volume of the actual blood is the same, but the volume of the blood vessels is bigger. So that you haven't actually lost volume, but the blood vessels can't kind of hold it. So it's kind of hypovolemia, but they haven't actually lost volume effectively. Does that make sense? I don't know. Don't know whether that makes sense. But we'll talk more about septic shock, I'm sure.
Well, we're sort of moving on to distributive shock now. So do you want to give us a bit of a description of distributive shock as you understand it?
So most shocks are vasoconstrictive. So if you have hypovolemia, obstructive, etc., they cause, the normal response in the blood in the body is to vasoconstrict to hold your blood pressure. But in like mild distributive or septic shock, you lose the ability to constrict your blood vessels. So that mainly comes from your like inflammatory cytokines, and particularly nitric oxide. That's like a very profound vasodilator. So from my memberships years ago, I seem to remember like interleukin 1, interleukin 3, tumor necrosis factor. I think that's the only ones that I ever remembered. That was my answer for everything. And basically you get nitric oxide production, and that causes vasodilation. So the body can't respond in its normal way that it would do to maintain, the ultimate aim is to maintain blood pressure. That's what the body's always trying to do, to maintain perfusion to the cells. So in a normal situation, the receptors would tell the blood vessels, I think it's like the sympathetic tone, and also like the RAS system, the angiotensin 2 causes the blood vessels to constrict. But in that, when you've got that nitric oxide, it just isn't able to do it. So and you also get the leaking of the blood vessels, so you get like loss of fluid and protein out of the vessels, which adds to the situation as well. And you get blood in the wrong places as well, so that's why they don't have the pale mucous membranes like the other ones. They have like, you know, injected or red mucous membranes, because they can't preferentially send blood where they want to, which is like the heart and the brain, that it just goes everywhere because the body can't respond as it normally would. That's my membership level as opposed to fellowship level.
Well, yeah, so we don't really do shock we do sort of, it's not internal medicine specialty, but unfortunately we have to deal with a lot of shocky patients, and that's why I think it's good to tap you in cases like this. I quite often find fluid somewhere and just hand it to Lucy and say, tell me if it's septic. So sort of in summary, that distributive shock is caused, the clinical signs of distributive shock are caused by a combination of a whole heap of impacts on the blood vessels from systemic illness. So vasodilation, increased vascular permeability. So we've got increased kind of circulatory capacity, decreased pressure in the circulatory system, and then we've also got leaking vessels. So we do end up with a little bit of decreased volume in the vessels, but we also we don't have dehydration in that case. We've got hypovolemia, but not dehydration. Also, a lot of these diseases are associated with decreased cardiac contractility. So there's decreased cardiac output to fill that increased vessel volume. And the other thing that happens in a lot of these diseases is that they're mostly inflammatory, and they activate the clotting system as well. So we get these tiny clots developing and blocking vessels, which then decreases venous return. So we've got decreased blood going back to the heart, decreased blood coming out of the heart, but also this big vascular volume. So blood pressure can drop quite dramatically from all those mechanisms. Then moving on to the third type. Remember, there's 6 types. I just always have in my mind 6 types, so that when I see a dog in shock, I'm kind of thinking which components of which have I got where. So third type is cardiogenic shock. Can anyone give me like a classic example of a patient that you would see with cardiogenic shock?
Heart failure.
Good. Yeah, absolutely. So decreased capacity of the heart to deliver oxygen to the tissue. So any disease process that causes systolic failure. So most of the time we talk about what we see most commonly, I think, is degenerative mitral valve disease. But DCM is also probably one of the more common causes of that, just because it causes such profound decrease in forward in systolic function.
Yeah, the way I think about it is like normal congestive heart failure is backwards failure, so they're just like filling up behind the heart, but cardiogenic shock is forward failure. They can't physically get the blood out forward, so something's stopping it. And like DCM's classic example of like they just have no ability to push blood forward.
Would that be things like atrial fibrillation as well? That kind of
absolutely
stuff?
Yeah. So arrhythmia is another really good example of that. So most arrhythmias will decrease systolic function and cardiac output, so it's a good example.
Pericardial effusion as well, that's kind of one of the ones that kind of straddles multiple groups.
This is where you've got to choose the classification system and stick with it. Yeah. So that probably segues really nicely into the next classification of shock, which is obstructive shock. And that's the decreased venous return to the heart, which then obviously causes forward failure. There's nothing for the heart to pump.
Yeah.
But it's sort of classified as a different category, mostly because you're going to deal with it differently. So obstructive shock, give us an example, someone.
GDV. You get like a one.
That's my favourite example to hand to Lucy.
Well, GDV straddles a couple because it is obstructive shock, so it blocks your caudal vena cava, so you've got lack of blood supply back to the heart. It also causes hypovolemia because there's fluid like extravasated from the stomach and the gut into the gastrointestinal lumen, so you do get hypovolemia as well. I guess in severe cases, like an end stage 1, you could get like septic shock as well if they've got like a really necrotic gross area that's causing like badness coming out. Like if they're really struggling, you can get cardiogenic shock as well because they just can't, they've got no blood to push forward basically.
They also often have arrhythmias, which might be contributing to forward function.
Yeah, for sure.
So I think probably my like sort of second most common one that we see is pericardial effusion, which decreases obviously the ability of the venous system to empty into the right side of the heart. So it's not sort of that classic obstructive like blood vessel, but it's certainly an obstructive shock. From a forward failure, like, cardiogenic shock and put them in together. Whoever's phone's ringing, do you mind just putting yourself on mute?
Question. Would a PTE be classed as obstructive?
Yeah, it would. Yeah, absolutely. Yeah. So we sort of, most of the obstructions, most of the venous system is kind of before the right side of the heart. So most of the obstructive causes cause right-sided kind of congestion. But PTE will cause a left-sided obstructive physiology. We've got a really amazing case in the hospital at the moment. A cat with its entire right lung is clotted.
Wow.
And its radiographs are so unspectacular for its degree of respiratory distress, but it is like, it's such a poster child for obstructive shock.
The good old, we can't find anything else, so it must be a PTE case.
Yeah, exactly. The CT images are just spectacular. Yeah. Anyway, he's actually doing quite well. So bringing us on to metabolic shock. And this is one that, as a medicine specialist, I get quite excited about because it's more, so oxygen is being delivered to the cells adequately. It's getting there. It's just that the cells can't utilize it. So it may be that the cells are hypoglycemic. So whether like diabetes, for example, where the glucose can't get into the cells and the cells don't have the glucose that they require for glycolysis, or something along the lines of cyanide toxicity, or a mitochondrial disorder, so puppies and things.
I was told anemia was also in that category. I don't know whether it truly fits what you've just described, but yeah, I always had the impression anemia was a metabolic shock. But
I think anemia is a hypoxemic shock.
Oh, okay. Is that the category?
Hey, different category.
Is that the next category?
Yeah. So it doesn't matter what classification system you use, as long as you've got everything slotted into a category. But the reality is that most of the patients we see don't just have one form. No. They've got hypovolemia and distributive shock, or, we're treating a combination, but it's just a nice way to remember it. So then moving on to hypoxemic shock. So we've got hypovolemic, distributive, cardiogenic, obstructive, metabolic, and then hypoxemic. So obviously, if there's not oxygen getting into the animal, it can't be delivered to the cells. So this includes like airway obstructions and things like that. It includes decreased oxygen carrying capacity. So things like methemoglobinemia or anemia, or carbon monoxide toxicity, for example. So all of those potentially causing decreased cellular respiration and energy production, and therefore cell death. So there are 6 types of shock. And then regardless of kind of what type of shock, the process of what happens once cells start to get damaged is pretty similar. And what I want to do is just for a couple of minutes go through the kind of clinical signs and the compensatory mechanisms that the body has. And then I'm going to kind of let the discussion flow a little bit more freely and less structured, because basically what was delivered in Edinger is not so relevant anymore with our newer understanding of how fluid moves in and out of the blood vessels. So essentially, clinical signs of shock. Mentation is one of the early ones. As we've talked about, neurons just have an absolute requirement for oxygen. They don't have any other way of producing energy or any capacity for anaerobic metabolism. So we see dull mentation in all patients with shock. And obviously you don't know that patient. You don't know what their regular kind of energy levels are and things. It can be subtle in the beginning for us, but really questioning the owners, like, do you think they're quiet or is this normal for them? Can give you an indication. But essentially, if the dog's bright, it's not shock.
I don't know. I wouldn't necessarily agree with that, because I think with the early, particularly hypovolemic shock, that they've got that compensatory phase. I think they often actually look agitated So I think they actually kind of go up before they go down. It depends what it is they've got wrong with them. But like, say you've got that dog with horrible gastro that's now reached the point that it's hypovolemia. They often come in like really agitated. They've got like the sort of that compensatory level, and then when you give them fluids, then they go down. So I think they kind of go like normal mentation, they go up, and then they go down. And I think that first phase is often the bit that kind of gets missed because they look bright and like they can't be hypovolemic. But that compensatory phase, I think it often kind of overcompensates a bit sometimes. So yeah, but then they go down to dull for sure.
Yeah.
Yeah.
So that kind of first phase is that compensated phase, and the mechanism of that is they get a bit of an adrenaline surge. So we've got catecholamines in the system, which will cause an increase in heart rate. We see an increase in respiratory rate to increase the oxygen level in the blood, and we see vasoconstriction as a result of the catecholamines as well. So the blood vessels constrict around a decreased blood volume, and the blood pressure stays stable. So externally,
it often goes up initially.
It actually, often, particularly
with hypertensive, which people get really freaked out about giving them fluids because they're hypertensive, but they need it.
So if we've got elevated heart rate and elevated respiratory rate, they're probably going to be the biggest signs. And obviously in a hospital setting, this is often when they're presenting. Patients to be a little bit tachycardic when they first arrive at a hospital anyway, so it can be really hard to detect. The other thing that sort of happens in this compensated phase is that the body activates the renin-angiotensin-aldosterone system and starts to retain fluid. So obviously in our patients that can't retain fluid, so patients with renal disease, patients on diuretics, or patients with any other cause of polyuria, so diabetes or Cushing's, they can't retain fluid and they become dehydrated so much more spectacularly and dramatically and fast. So they're the ones that, particularly in this early phase, it's really important that we're not saying, oh, they're hypertensive, I'm not going to give them fluids. We're going to give them fluids in this phase. Then we sort of move from compensated to early decompensated, where we start to lose perfusion. So we start to see an increase in capillary refill time. Does anybody else want to tell me what they look for with it as their kind of markers of perfusion in a physical exam? Nope.
Like a CRT and extremity, like pore temperature.
Excellent. Very good.
Your like pulse quality and heart rate. So you're
very good. Yeah.
The colour of the pads on cats' feet can be a giveaway, and you see that with alpha-2 agonists.
Yeah. That's a great point, actually, because a lot of the time in cats, capillary refill time is really unrunreliable. It's just hard to get. Their gums just aren't big enough.
And they always look pale.
Always.
No matter what you look at.
Exactly. So that all really good points. And the other one, the temperature of the extremities, somebody mentioned, that includes the rectal temperature. So if we start to see the rectal temperature dropping down from what it originally was in a patient in hospital, I'd be concerned about that. In the later phase, a late decompensated phase of shock, we start to see bradycardia, profound mentation changes, so sometimes comatose patients. Pulses will become progressively less palpable as perfusion decreases. And this is where we start to see low blood pressure. So they've nearly fallen off their perch by the time we see blood pressure drops, because those compensatory mechanisms are so efficient in most patients.
Yeah, I think that's a really important point. Like, blood pressure is a really, really late indicator of shock. A normal blood pressure does not mean they're not in shock. Like, the body is doing everything it can to maintain blood pressure, and it's only when it really has got to the point where it can't maintain blood pressure anymore that it will show. So although blood pressure is important and you should check it, like a normal blood pressure does not mean that everything's okay, because it just means the body's doing its job for the moment.
Yeah. So we've sort of talked about the compensatory mechanisms now. I would just want to move on to where the fluid's going with the different types of shock. And I think probably distributive shock is the one that in fact, so all shocks cause decreased cell metabolism, right? So the cells body-wide are getting decreased amounts of oxygen. And that includes the endothelial cells that we're relying on to contract around a decreased blood volume. Those endothelial cells become a little bit leaky in all forms of shock, and that happens much earlier in a lot of, anaphylaxis and sepsis and SIRS and things. We get increased transcapillary shifts in those types of shock. Now, traditionally, we thought one of the compensatory mechanisms in shock was shift of interstitial fluid back into the vascular space, down its concentration.
It's the groover.
Dave,
mute
I'm
yourself.
watching a Zoom seminar.
Dave, mute yourself.
Mute yourself.
Yeah, well, it's on shock therapy in there, and I'm not on.
I'm going to mute him.
That's good.
All right.
No. I'm just listening. I caught it.
Got him. Excellent. Okay, so this is where it's changed. We sort of think inside the blood vessels has become dehydrated, but the interstitium is still well hydrated. So we're going to see a fluid shift between the interstitial compartment into the vascular compartment. And this is a pretty big shift in thinking recently. Lucy, do you mind explaining what we now know about fluid shifts?
All right, I was reading up on this last night because it was a few years ago. So basically, the original Starlings Law suggested that you effectively with your blood vessels, you've got hydrostatic pressure pushes out and oncotic pressure pulls in. So water pressure pushes out and protein pressure holds stuff in the vessels. That's traditionally what we were told, right? You need protein in your blood vessels to hold in. And the thought was that you could basically, it could go both ways. So water goes out, but also can come back in under certain circumstances. So hence where colloids and stuff came from, that the idea was that you'd give them protein and it would kind of suck fluid back into the blood vessel. Really, that's been disproven now. So water can leak out of the vessels, but can't leak back in. It can't be sucked back in like we traditionally thought. It only goes back into the vessels through the lymphatics, effectively. So the lymphatics, I think we sort of maybe all kind of discredit the lymphatics as kind of this backup plan for volume overload, but really apparently everything comes back through the lymphatics. So the glycocalyx, which is this kind of protein gel layer on the inside of the vascular endothelium, apparently was actually seen on electron microscopes back in the 1930s, but they just kind of ignored it because it didn't fit with kind of what people thought. So, but the endothelial glycocalyx has been found to be really important in everything. It's way too much to go into in this, but basically it acts as a barrier against the endothelium. So you've got the blood vessel cells on the outside, then you've got this layer of glycocalyx, and they say it takes up about 15 to 20% of the blood vessel volume. So it's actually quite a large amount, and it's got proteins and proteoglycans and things in it, and it measures shear and all sorts of stuff. It's really does a lot of things, but basically you always have more albumin outside of your blood vessels than you do on the inside anyway. So this idea that you can kind of suck it back in is irrelevant, and the pathway just doesn't allow that. So yes, if you have increased volume in the blood vessel, it will leak out, but you're not sucking it back in again by giving them protein. This is where the kind of what fluids to give shift has come from. So when you look at a cross section of the blood vessel, if you give crystalloids, the crystalloids will go into all parts of the blood vessels. So it will hydrate the endothelial glycocalyx, and it will hydrate the middle of it as well. If you give artificial colloids like starches or gelatins, it only sits inside the glycocalyx, and it actually damages the glycocalyx. So the glycocalyx gets smaller, the middle gets bigger, but you're not actually hydrating the whole thing. They've also found that red cells go down the middle, they can't get through the glycocalyx. And actually, the way the guy described it was like, it's a bit like being on a snowboard in powdery snow. While blood flow is moving, the red cells will just keep going through and won't kind of sink into the glycocalyx. But as soon as you get stop of blood flow, so if you've got like a clot or something like that, the cells actually kind of fall into the glycocalyx, and that's where they think that the sort of coagulation activation comes from, because it then allows contact of the red cells to the endothelium, and because the red cells only sit through the middle and actually seem to be kind of retarded by the glycocalyx. If you give colloids, you're increasing the volume of that middle bit, but you're not increasing the red cells. And there's actually a condition called anemia of colloids, because basically you're diluting out that middle bit. So I think basically it just means that we're not sucking fluid back in. When we give colloids, we're not sucking fluid back into the thing. And really the evidence is they probably don't help, and they may well do quite a lot of harm. They do potentially damage the glycocalyx. Also, as the blood vessels go through the liver, if you give colloids, it pushes the albumin that's in the bloodstream out to the edges, and then as it goes through the liver and it goes through the sinusoidal capillaries in the liver goes, oh, you've got loads of albumin, because all the albumin's been pushed to the outside and therefore doesn't produce any albumin. So you're actually retarding natural albumin production in these animals. So really they say the most leakage you get from blood vessels, you don't really leak from your like veins and venules, you leak from your capillaries. So the best place to try and minimize leakage is your capillaries, and that's where the idea of all the vasopressors came from. So using noradrenaline, you're trying to reduce blood flow into the capillaries and therefore reduce leakage out of the capillaries. So I did ask him when I was there about hypertonic saline, because that's a crystalloid and we have in our minds that it sucks fluid in with its osmotic effect. He didn't know, because he said he doesn't use it, and apparently in humans they don't use it very much. He thought maybe it causes vasoconstriction, but couldn't really give me an answer, because obviously that doesn't fit with everything else. It's a crystalloid, but it seems to, suck fluid back in. So really the basis of treatment now has gone away from this idea of trying to hold protein in the cells, because we know it's not going to work and it's potentially going to make the situation worse, and trying to minimize leakage at the capillaries, which is where it all goes out, basically. That's my dumb down. I've got like pages and pages of stuff. But I don't know, did you send the paper that you wrote, the BJ paper, the Revised Starlings thing?
I sent it to people who requested it.
Okay, cool.
But I just wasn't sure about privacy. Like,
I just got it off the BJ website, so I don't think there's an issue. The other bits were from IBEX, so I don't know whether we should spread them, but the paper's like out there. I didn't pay for it or anything, so
okay, cool.
So basically the guy that spoke at IBEX a few years ago, Dr. Woodcock, who looked like something out of Midsummer Murders, he wrote a paper. He was like in his, I don't know, 60s. He was a human criticalist who then went into like research. He wrote a paper with his son, who is the other Woodcock, and he did a PhD on something that I can't remember. And basically they wrote this paper together, the Revised Starlings Law, and it just basically talks about, when you look at textbooks, you see this like reversible arrow where fluid goes in and out of the blood vessels, and he just puts like a big slash through it in one direction. It's like, no, it doesn't go that way, it only goes that way. So that's the crux of it. So colloids are out. I mean, look, I think it's like everything in veterinary medicine, like probably in 5 years we'll be having a different conversation, because it's always changing, isn't it? But so like I think this idea, you could argue, like Donna, for example, still uses a bolus of Voluven for the hypertensive patients because she feels it's fine. But I think this idea of giving them Voluven like as a CRI to help with oncotic pressure is just not really valid anymore. I think, and they were saying you need less than 10% of your less than half of your albumin to be normal, and which is basically an albumin of 10. So you only really need to worry about the lack of albumin less than 10. Like, so really low numbers. If they're leaking and their albumin's 15, it's not the albumin that's the problem, it's just the leaking of the vessels type thing. So basically vasopressors, and that's where that whole shift has come from. Yeah.
And all those colloids also interfere with platelet function?
Possibly, I don't know. I know that in humans they're saying it causes a lot of renal problems, but they use massive doses in people. That's where it's really come away from in the humans, is the renal side. Don't know about platelets, but
there has been some studies that suggest platelet thrombopathy associated with colloid use, but platelet function testing in dogs and cats is in its infancy in testing. We just don't understand them very well. So there's a couple of things that, like, you talked about colloids, and I just wanted to clarify, we're talking about synthetic colloids when we talk about that. Yeah. So what about the use of plasma as...
Well, I think, like, we all know that plasma is really poor at increasing albumin at the best of times. Like, you need massive volumes of plasma. I think really the only indication now for plasma is active hemorrhage from coagulopathy. So even in, like, your DIC patients, like Kate Hopper was saying at UC Davis, they actively don't check coags in septic patients because she says it tempts people to give them plasma. So they only give plasma if the animal starts actively bleeding. So, like, from venipuncture sites or, you know, epistaxis. If they're not bleeding, they don't care what the numbers say. So I think really, like, an active coagulopathy is the only indication for plasma now. I think the only, like, aside from that is maybe like a very young parvo puppy that only weighs like 2 kilos. Maybe you could give it a decent enough volume of plasma to actually, like, truly increase its you know, albumin amount. But really, in an average sized dog, like, it's not going to hit the sides. What is it? I think it's like, you know, what is it, 100 mils for every one increase by 1 or something per kilo, or so. It's some ridiculous number. So giving plasma is never going to increase your albumin effectively in a decent sized animal. In America, like, obviously a lot of it was American based, they use a lot of human albumin, and really he was just like, don't do it, because again, like, it's highly antigenic to dogs, but also, like, again, it's telling the body your albumin level is fine and therefore it doesn't produce any albumin. So he basically put, like, human albumin in the same category as the synthetic colloids. So I think our plasma use has gone down significantly. I probably use it mainly for rat baits now, really. Yeah.
I'm sometimes tempted.
Yeah. Don't be. Sometimes you just better not to look. Like, I think, well, I mean, also with our clotting times, we're still measuring PT and APTT, and we know that, like, we've now got the cell-based model of coagulation, which is, like, completely different. Like, we're testing off one model, but we're actually know that it's completely different now. So what does it actually mean? Like, who knows? Do you know what I mean? Like,
well, what I find difficult with a lot of our shock patients, you sort of say you don't transfuse them unless they've got, well, you don't give them plasma products unless they've got evidence of bleeding. But so many of our shock and SIRSI patients have melena from intestinal injury. Is that bleeding, or is that just expected gastrointestinal injury?
I don't know. I think the melena is probably due to more maldistribution. Like, I suspect it's more just shock rather than true coagulopathy. I think it's lack of distribution, because, I mean, like, you know, you get that anaphylaxis patient and you're just waiting for the hemorrhagic diarrhea. Like, it's going to come no matter what you do. Do you know what I mean? So I think it's basically the gut catching up effectively. But, you know, I mean, like, to get true melena due to the platelet numbers, you've got to get, like, way down there. It would be like 10, or I don't know, what's the magic number for platelets?
30.
Like 30.
Or 25 to 30.
Yeah.
So that, speaking of shock guts, can we talk about it's not written in the textbooks in very clearly, but different species have different shock organs, right? So any sort of cause of shock in a dog, for example, what organs would you expect to be worst affected relative to a cat? It's not a test.
Is that me? I thought that was a general question. I was waiting for it. In a dog, it's gut for sure. Dogs get diarrhea for or a multitude of reasons. So, we see shock gut a lot. For dogs, it's gut basically. That seems to be their weak point. Anaphylaxis will very commonly see severe hemorrhagic diarrhea post anaphylaxis. We commonly see hemorrhagic diarrhea due to any kind of sepsis, so septic abdomen, severe pancreatitis. Their gut just is not happy. So a lot of when I talk about the just treatment of gastroenteritis in general, when I've just got a dog that comes in with vomiting and diarrhea, I just say what we need to do is perfuse the gut and give it a chance to heal itself. I think we kid ourselves that we actually make much difference with the gut. The gut's actually really good at healing itself, but it just needs to be given the best ability to do that. And really, I think the basis of that is fluids. So, the amount of dogs I see with HGE, as I like to put it, AHARDS, AHDS, you give them a fluid bolus and they never have HGE again. They come in with HGE, you give them a fluid bolus, yes, they've got diarrhea, but they don't have any more hemorrhagic diarrhea. And all you've done is given that gut a chance to heal itself, basically, to perfuse it. Because the last place the body sends blood supply when you're shocky is the gut. That's why it's the kind of, you get the stress diarrhea, because your body's got sympathetic tone and it's sent the blood to your brain and your heart, and your gut's left out and it's the dump and run. So I think we just need to make sure there's perfusion in the gut. Obviously, secondary issues with the shock gut, particularly with the septic patients, is then you worry about things like bacterial translocation. If the gut gets a bit leaky, are they going to get secondary leakage from there? I'm not sure. I heard recently that maybe that doesn't happen. It's a bit controversial, the whole bacterial translocation. I don't know. I'm a bit behind the times on that side. Anna?
I don't think so. I think there is bacterial translocation, but there's always a degree of bacterial translocation. All of that blood goes directly to the liver to be filtered by reticular endothelial system. So we see gut liver circulation of bacteria all the time. So if you take a photo of a normal healthy dog's liver, there's bacteria all through that kind of cycle.
Yeah. It doesn't get any further, basically.
Exactly, because all of that circulation is going into the portal system and straight through the liver, straight back into the gut. So where there would be an exception to that is if there's shunting, and that importantly happens fairly early in cats with anorexia and things. So, a lot of our patients also have hepatic compromise associated with their shock. So that's sort of going back to which species are affected worse. I think dogs definitely get shock guts. Cats get shock guts a little bit, but they also get shock livers and shock lungs.
Yeah, shock lungs in cats is I would say the main issue. Yeah.
So respiratory rate goes up very early in cats as one of their early indicators of shock.
My understanding with that is they don't have very much they don't have very much reserve or something in their lungs, is it the lymphatics or something? I seem to remember that they can't cope with big changes in blood pressures or something. There's just not that much.
I actually don't know the mechanism of it, to be honest. I think I probably did at one point in my career, but not.
Maybe I'm thinking of why they volume overload, why we're cautious with fluids with cats. I think that's it. That's what I'm thinking of more than true shock, is that they just don't have that much lymphatic reserve compared to other animals. So if you do give them a lot of fluids, that's why they're so prone to getting the edema.
And I think it's to do with their mast cells as well. They've got a lot more mast cells in their lung, and dogs have them in their gut and liver. So that's why with anaphylaxis, they tend to get this massive bronchoconstriction, whereas in dogs, it all happens in the liver.
Well, bronchoconstriction, but also increased vascular permeability. If you get a massive histamine release in your lungs,
not a good thing.
Yeah, not a good thing. That's a poor design.
So you're getting I always thought that too. It's huge inflammatory release. So you get that. It's protein rich edema that the cats are getting from a huge inflammatory response in there.
Yeah. Okay.
Cool. I don't know if it's right or not, but that's what I always thought too.
Yeah.
Yeah,
I think
interesting.
the mast cells ring a bell because I remember that coming up on a question and everyone was like, oh, but yeah, that is mast cells. Yeah.
I'm trying to convince Helen to go through fellowships. I ask her questions now, and she's got like
the book of knowledge. She should publish that thing.
I know. She told me the sensitivity of a pro-BNP off the top of her head test the other day, off the top of her head. Like,
only because I just read it.
Book of knowledge. Yeah.
All right. So should we go through like the case example? And what I want to sort of quiz Lucy on is how she develops her kind of resuscitation plans in these patients. So if I throw a case at you, Lucy, can we kind of talk through what you do and why?
Hey, Anna, can I just ask a quick question?
Yeah,
or actually maybe towards Lucy. But I was just wondering about in GP land where you get a dog that comes in and it's just got, you know, pretty mild diarrhea and it's actually not too shocky, just a little bit tacky. Are those ones, a lot of people want to send them home on outpatient without giving them any fluid therapy and just sort of monitoring from that point of view. Do you think we should be giving them a bolus of fluids? If you're talking about that gut,
I don't think a bolus of fluid would be helpful because you're treating the hypovolemia, but you're not treating the secondary dehydration, which has led to the hypovolemia. So if you are seeing signs of a dog that has even mild hypovolemic shock due to gastroenteritis, i.e. vomiting and diarrhea, they've gone through levels of dehydration where the body has coped with it and now the body can't cope with it, and that is showing you the hypovolemia. So just giving them the bolus, which is actually a very small volume, is not really going to help the grander scheme of things. Yes, if you get that diarrhea animal that comes in with a completely normal heart rate, normal capillary refill time, normal mucous membrane color, it's moist, you know, go for treating it as an outpatient. But like I feel like the perfusion parameters like heart rate, pulse quality, like capillary refill time. So like fast capillary refill time is as abnormal as slow capillary refill time. And again, I think people miss that. Injected mucous membrane, so often they look very like flush. Those animals need fluids, like in a decent amount of fluids. We actually had a discussion the other night about like protocols within the practice, and HDE, now HARDS, came up, and you know, metronidazole versus non-metronidazole. And my personal opinion is like I think you're much more effective at getting those animals in, even for like 12 hours of fluids without metronidazole, and sending them home on dehydrated but on metronidazole. Like I think you're doing them I mean, if you can orally rehydrate them, then go for it. So sometimes just giving them a jab of meropitin and you can send them home like with some oral aid or something. If that works, fine, but there's no benefit to just giving a fluid bolus and then sending them home. You might get away with like 12 hours, so if they came in that morning and go home that evening, if it's very mild, but like the volume they've taken to get to that point is more than a fluid bolus, basically.
Okay, great.
Yeah. And I think the main thing with these gastro dogs is you're only seeing what's on the outside. You don't know how much diarrhea is in them. Like the amount of times we suddenly see a spike in heart rate, respiratory rate, like they look like they've had a really bad blowout of diarrhea, but nothing's come out yet. And then like a few hours later, they suddenly have this big volume. Like the volume is out of their body if it's in the gut, even if we're not seeing it yet. So that's like, you know, that's why we keep them in for 12 hours after they stop having diarrhea, to make sure that there's not more on the way type thing. So
I guess I base that a little bit. I always do rectals, and then I'm looking at
and you often get that like dilated rectum, and you can you get the idea that something's on the way. But no, I don't think just having them in for a fluid bolus is gonna help. I mean, obviously, you know, there's a perfect, you know, let's face it, we don't go into hospital every time we get gastro. We just like do our best to rehydrate ourselves. So probably the majority of them would get better without fluids. They just take a lot longer. Like, you know, we don't, you know, it's just time really with gastro, isn't it? But I think if they're showing signs of hypovolemia, they need to come in on fluids for a decent amount of time. And that would be really a minimum of 12 hours, I'd say.
Great. Thank you.
Yeah.
Dave, I'm going to add to that. I think restoring their ability to hydrate themselves with anti-nausea medication, like even if it's only diarrhea and they haven't had any vomiting, if they're not eating and drinking well, they're probably feeling a bit nauseous, and anti-nausea medication, very low risk of side effects with meropenem.
And like meropenem, probably pain relief as well. They've probably got a bit of gut pain. Like,
really. So that's going to get them out of hospital much sooner.
I'll be honest, I'm a convert to sending them with oral meropenem as well. I've got on that bandwagon. Because like sometimes you give the injection, but then maybe they'd have them at home just as a backup if they're not quite eating right. So I think particularly cats as well, because they get so much fluid through their food. If you can keep them eating, then they'll rehydrate themselves over time.
Yeah.
What are your thoughts then if you got a cat of using an anti, like a metazapine combination with, say, omeprazole or something like that, to try and, if you want to keep their appetite up?
Yeah, I think that's fine. The problem with metazapine in cats is you probably can't really give it safely more than every 48 hours, and most of the time the gastro is done by the time you're up to the second dose.
Yeah, that's true. Yeah.
So
you probably got enough to do the first one. Yeah.
Okay, great.
All right, hit me with this case then.
Okay, all right. We've only got about 3 more minutes. So
okay.
All right. We've got a 30 kilo. I'm going to actually make it a 10 kilo.
Okay.
Just for ease of calculations of fluids and things. 10 kilo, 6-year-old male neutered terrier with no other underlying conditions.
Yeah.
Presents having been stung by a bee and acutely collapsed.
Okay.
On presentation, heart rate is 200.
Yeah.
Blood pressure is low. And mentation is obtunded. Okay.
So the main thing with anaphylaxis in dogs is it just causes a massive vasodilation. So the first thing really is fluid boluses. So I would give it a 10 ml per kilo fluid bolus over 10 minutes and reassess. You'll probably need to give it a few. Depending on how quickly it responds, I'd be looking, so if it's been stung by a bee, obviously you want to get the bee stinger off. I'd get the ultrasound out to look for gallbladder edema, although if it's not there, it doesn't necessarily mean anything. And look at the chorda vena cava, so as it goes through the diaphragm on the DH view on ultrasound, and generally you'd expect it to be collapsed with an anaphylaxis. I guess another way that things can present like that is pericardial effusion. So we always check for pericardial effusion as well, although we don't have a strong history.
That's think particularly a greyhound thing for anybody that might see greyhounds. Greyhounds with anaphylaxis love getting pericardial effusion.
Okay, and apparently heme abdomen secondary to anaphylaxis is a thing as well. I haven't personally seen it, but it is a reported thing. So if you see a heme abdomen with a probable anaphylaxis, don't automatically think it's got a splenic mass. So yeah, basically the mainstay treatment for anaphylaxis is fluids and more fluids. So that's the first thing. So I normally give like 2 to 3 boluses of fluids. I'll be honest, majority of the time that's all you need. I do give steroids and antihistamines, mainly for shits and giggles because it makes me feel better. It takes like, I think 2 hours for DEX to kick in, and the antihistamines may or may not do something because they're like, we always think they're kind of super safe. So they're not the mainstay of treatment, but I do give them mainly to make myself feel better. If they're not responding to the fluid boluses, so we normally say you can give up to say 3 crystalloid fluid boluses. If I wasn't getting blood pressure up at that point, then I'd be looking at adrenaline CRI to increase vascular tone. In an anaphylactic patient, initially at least, they're purely hypovolemic. They're not, or they're kind of an effective hypovolemia due to the vasodilation. So they're actually a maldistributive, but they're not actually dehydrated at that point because they're a normal animal that's walked and then collapsed. However, they often do get pretty bad shock gut afterwards, so then they can certainly become hypovolemic afterwards. So it's just worth having that on your radar. So, I guess how far you go down the treatment options depends on how they respond. I'd say fluids is the mainstay of treatment for these guys, but you know, if they don't respond to the fluids, then adrenaline CRI basically. I think we've really gone away from just a one-off adrenaline injection, because it's very transient. They used to be like give it subcut adrenaline, but all it does is just kind of cause vasoconstriction in the area that you give it, and then you potentially get secondary effects with that. So really, adrenaline CRI. I've had a few questions recently about EpiPens with people like wanting EpiPens for their animals, and Yvonne actually asked one of the criticalists at SASH, and she said really EpiPens aren't appropriate for dogs because in people they use EpiPens for the bronchoconstriction that you get, like the airway edema, and we don't, dogs don't get that. So dogs get a vasodilatory shock with anaphylaxis, so they just need fluids, like lots and lots of fluids. And I think the main thing with fluids is, you know, you give enough. So we start with kind of ballpark numbers of what we want to give based on that size, but you have to kind of tailor it to the animal. So you give a bolus, you reassess, you give a bolus, you reassess. Like if 6 hours later it suddenly looks really like dry again, then give it another bolus. Like you've there's often like diarrhea that you're not aware of. You just got to kind of react to the animal. I always say they need enough, but not too much. So, but yeah, fluid anaphylaxis is fluids. Like if you don't remember anything else, like fluid boluses. I had one recently sent over from one of the ref vets, and I literally, it was like a 50 kilo Bernese, and I gave it 3 liters of fluids, and it just went from like staggering around, hardly able to walk, to like up and about, totally fine. Like I gave it steroids and antihistamine to make myself feel better, but like they'll go from like white as a sheet to good with just fluids a lot of the time. Yeah.
Okay, cool. My only experience with an owner having an EpiPen, I told her she couldn't have one. It was a 10 kilo dog that kept collecting in the park every time it trod on a bee.
Yeah.
And she sourced one herself and then tried to inject the dog with it, and it went through and through into herself and she got carted off in an ambulance with an everything. I was like, I told you.
Yeah. I think you can, like, I wasn't aware, I'll be honest, it was only because recently we'd been investigating, but apparently they're not even indicated. It's not just like lack of availability or cost, it's like they just truly would not be helpful in a dog anaphylaxis just because they're different. So if anyone asks you, you can argue that. Yeah.
All right, thank you so much for joining us, Lucy.
That's all right.
Everyone for coming. I'm going to wrap you all up now. If anybody missed out, we'll send out the recording or put it on the app. And if anyone's got any questions, feel free to flip me through an email. Just reply to the email that I sent through, and I can forward to Lucy if I don't know how to answer it. Thanks so much, everyone.
Thank you so much.
Bye.
Have a good day.
Bye.